Good evening. Thank you for coming to this little seminar. We're going to try to give you an overview of some of the things that we do here regarding total hip, knee, and shoulder replacements. Give you a little information on why you might need one and what's new and what's not new and what's good and what's not good. In about half the time it needs to do all that. But we'll see what we can get and give you some information. But all three of these joints have become much more frequent over the last years for a variety of reasons. One is attributed to the aging baby boomer population, which has brought more people into the age range that typically need joint replacements. Another factor is the success of the replacements, and the longevity has improved over the years. Although the changes, at least in hip and knee replacement, were more 20 years ago, the longevity started increasing. But now we've also refined the techniques and improved the speed of recovery with a variety of things, many of which Mark Kroskowski, the anesthesiologist, will talk about, with nerve blocks and multimodality pain management protocols, more aggressive physical therapy, getting you up quicker. And we have these protocols established that where we try to move people along a care map and get them mobilized quicker and out of the hospital. When I started doing this, hospital stays were 10 days to 12 days, and that was a half of what it was when they started doing it 10, 15 years before that. They were like 21 days. Now we're down to 3 nights, and people are moving, a lot of them capable of going home at that point. Some people will go to a rehab facility and get a little more help at home, get a little more therapy and a little stronger before they have to get home and on their own. The reason for joint replacement is typically arthritis. Sometimes fractures and other things that can cause arthritis will be a source of it. But it's most typically arthritis, and most common would be wear and tear arthritis. What that is a loss of the joint cartilage. If you've ever ripped a chicken wing apart or a chicken leg and seen the shiny stuff in the joint there, that's the cartilage. When that cartilage is worn away, the bone is exposed, the bone has nerve endings, and you have pain, and one of the solutions would be joint replacement. When it's as bad as the picture on the other side there, there's not much that's going to help it other than replacing it. This knee has big spurs around the outside. It's got areas of exposed bone, and the cartilage is gone. Before you get to that point, there are temporizing measures. There are injections you can do. Cortisone can quiet things down for a period of time. We inject hyaluronic acid, which may give some benefit for several months. In some people, it doesn't always work. People colloquially call them lubricants. It's just normal joint fluid. People are experimenting with other things to inject. We don't really have the capability of delivering stem cells. I'm sure you've all heard about stem cells, which can differentiate into other cells in the body. We don't really have the capability of delivering them to the right spot to fix arthritic knees or joints yet. But someday, maybe. And so people are experimenting with various other things they might inject into a knee that might delay the arthritis. There are anti-inflammatory medicines that you can take, like Advil or Aleve. There are prescription ones that you can take less often. They all work about the same. You can do strengthening exercises. You can get on a bike and spin. The repetitive motion of the bicycle can help smooth the knee surfaces and lubricate the cartilage and polish off any little rough areas and preserve the knee for a period of time before you need knee replacement. And then ultimately, when you can't put up with it any longer, you replace it. The timing is when you're fed up putting up with the pain and the discomfort, the stiffness, and the lack of ability to do things. For most people, they can't walk, they can't play golf or maybe tennis. Wakes them up at night, bothers them if they go for a long walk or to a museum or something, and that night they can't sleep or they have pain afterwards. So those are the kinds of things that put people over the edge and say, I got to do something. And if we can't make you better without surgery, with one of these non-operative measures, then surgery is the answer. So symptoms: pain, stiffness, swelling. In the knees you get deformity because one side of the knee or the other will wear out, and you can get knock-kneed or bow-legged as the joint space narrows down. The knee can get wobbly, instability can give out. A lot of times the giving out is because the bone is hitting the bone and you're getting a sharp pain in there, and then the knee will buckle. Certain types of arthritis, that happens more commonly, like when you have the knock-knee deformity. And that buckling could lead to a fall and an injury to something else, so that sometimes we will tell you, you shouldn't really put up with this, even though it may not be bothering you that much. If it's buckling, you might fall and hurt something else, so maybe we ought to fix it. The diagnosis is based on your history. We do a thorough history of your symptoms, etc. Examining the knee to check for loss of motion, alignment, stiffness. Make sure it's not your hip or something, because sometimes hip pain refers to the knee, and it's not the knee, but it's the hip. Sometimes it's your back, and it's sciatica running down the leg or a nerve that's being impinged. We'll do x-rays of the knee, verify the arthritis. If we don't find arthritis there, we might do an MRI and see if there's something else. If your symptoms don't match the x-ray, we might do an MRI to kind of look at the things a different way and see if there's another cause for your pain. Or maybe we're barking up the wrong tree and we need to look at your hip or your back or something. So the x-rays will help confirm all that. Total knee replacement, there's a lot of stuff on the internet, a lot of which is market-driven, trying to advertise some new device, which may not have scientific studies to really support it. Some of which is developer-driven by people who are getting royalties on these things. Some of it is just trying to, garner market share by saying they're doing something different. Minimally invasive kinds of techniques. As you can see, this is the knee. If you take the skin and the fat off, this is what is outside your knee joint, and it's encased in muscles and tendons and ligaments. So you have to cut something to get in there, and so people say, we're not cutting this or that. You have to cut something to get in there. There are different ways of doing it. The traditional way is to cut along the tendon and separate the muscle, move the kneecap to the side, and then put in the components. You can do it with a less invasive technique, a smaller incision. You can come in under the muscle here, which I like to do. And so we do what's called a muscle sparing approach. We come in under the quad, slide it over. The walking recovery is much faster with that because you're not doing as much damage to the muscle tendon unit. But the bending still takes a period of time. But most people can walk without a cane in 10 days if you use that approach. It's not a widespread approach. People are doing it, but a lot of people still do the traditional approach, and it takes a little longer to get walking with that. The bending is a little faster with the minimally invasive approach. Anything where you do less soft tissue dissection and stuff, it's going to get better a little faster, but it still takes 6 or 8 weeks, no matter what, to really get over the knee replacement. And they get better for a year. It's a prolonged process of recovery, and the soft tissues need to recover, and that's the biggest thing with the knees. There's a lot, as you can see, it's encased in ligaments and tendons, and those have to be balanced and dealt with. So you can do a minimally invasive muscle sparing approach, which we do here, and that works out well. There are some advances over the years. When we first did total knees, we would just kind of line up things and cut the bone and put it in. And then that didn't always work so well. And people did well for a few years and then it would fail. So then we found that you needed to predictably get the alignment in a certain way. You want the knee parallel to the floor. You don't want it, crooked or, out of whack. So you want the knee parallel to the floor. So there were instrumentation systems that were developed to facilitate that. And those required basically that you instrument the femur. You put a rod up the femur and set jigs. And you could do that on the tibia as well. You could put a rod down the tibia, or you could use an external jig. The problem with that, and it worked well, it wasn't perfect, but it worked well. But you did get putting the rod up the femur. There is marrow in the femur. There's fat in that marrow. And the bone has open trabeculae, open channels that communicate with blood vessels. So that fat could get into the bloodstream, up through the veins. The lungs would have to filter it out. People would get hypoxic, we call it. They'd have decreased oxygen content. We'd have to give them oxygen. They'd, have breathing. They wouldn't be oxygenating quite as well as we'd like them, so we'd have to supplement oxygen. They could have an embolus. They could have a fat embolus, we'd call it, where the lungs would filter out too much of this fat, and it would be harmful to them. And it could cross over skip the lungs and go to the brain and cause confusion postoperatively if people had a atrial septal defect, a little hole in one of the chambers of the heart that would allow it to communicate. So we've switched to a system of computer navigation, which allows us to use a computerized system with pins and trackers, infrared scans, and we put these little pins in the bone. This is the femoral tracker here. Mark some points on the end of the knee and do some maneuvers with the thigh bone and the computer has an algorithm that tries to tell you where the center of your hip joint is, because basically we want the knee to line up with the center of your hip, center of your knee, and center of your ankle. So we use we move the hip through a range of motion. It creates a estimate of where the center of the hip was. That's pretty accurate. Sets the alignment perpendicular to the mechanical axis of the leg. And similarly on the tibia, we have another set of trackers for the lower part. And we align that to the ankle and the axis of the tibia with a similar system. We do this, by doing this, we don't have to instrument the bone, so we're not putting rods up the femur and showering all that fat into the bloodstream and into the lungs. So it's safer medically. It's a relatively new technique. It hasn't. We've been doing it here for many years. Most places aren't doing it. I think it's safer for the patient medically. Does it give me better information? I actually studied the first couple hundred of these that we did with it's called Stryker Pinless Navigation. Checking the alignment and compared them to the last 200 total knees that I did with the old system. And the results were comparable. There, maybe a few less patients outside the plus or minus 1 degree, which was our goal from the mechanical axis. But you can see here 2 knees, and the joint line is basically parallel to the floor. And this is the appearance of the femoral part, the tibial part, and there's plastic in between that you don't see. So we validated the system and have presented that at meetings. But it takes a little longer, and there's a little extra work for the surgeon, and so it hasn't been widely embraced because it's a change, and people like to do what they're used to doing. And change can be slow to come about. But I think it's a good change. I think the biggest reason is it's safer for the patient. You'll see a lot of stuff on the internet, and I kind of talked about that you have to be careful of that. There's a whole bunch of stuff on different kinds of knee replacements. Most of them are very similar. They're basically a femoral component and a tibial component. I use a rotating platform knee that has the ability to pivot. It has better wear data, I think, than other knees. Some people, use other knees with different designs. They say their wear data is better. Then there's a thing called unicompartmental, and a lot of people ask about what's a unicompartmental knee. That's basically a half of a knee. But it's even less than that. It's really about a sixth of a knee. And then there's a little piece that goes on the tibia. Personally, I don't think it's a great operation for most people. There are some indications for it. Some people will do well with it, but the revision rate is high. A lot of people, it fails for persisting pain or ligament imbalance can fail in a couple of years, and then you're converting it to a total knee. It can fail because the rest of the knee that's not resurfaced can wear out. And it can fail because it can loosen because the pieces are very small. These are pretty big, and so it's going to distribute. There's a lot of load in your knee. About 10 times your body weight goes across some of your knee, aspects of your knee. So this distributes the load more evenly across all the surfaces. If you cut that off, you don't have a lot of load-bearing capability, and so there's a lot more strain on the interfaces of the implant with the bone, and so they can loosen. So there's a variety of reasons for failure. Most of them are failing before 10 years. And the revision of those, the people who put them in, the sports guys will say, oh yeah, it's an easy procedure. It's not necessarily such an easy revision. People have continued pain in the ligaments. There's things that happen to the knee when a total knee fails that in a unicompartmental that compromise the outcome of the revision to a regular total knee. And you may have to use more augmented components in the revision to supplement for bone loss and stuff. So unicompartmentals for most people is not the answer. You're better off just having the total knee, and you're more likely, 95% of the total knees are doing fine 20 years later. They can't say that about the unicompartmentals. They 50% may get 5 to 7 years out of them. And then you're having another operation. So you might get better 2 weeks sooner, but with the techniques that we have here with the nerve blocks and minimally invasive approaches, the computer alignment, they're not really getting better significantly sooner. And they're facing a second surgery to convert it to a total knee when it fails. So you have to be careful about this stuff on the internet because that's market driven basically. Unicompartmentals have been around for 30 years. The original knees were basically unicompartmental, and they failed quickly, and so they were modified over the years and taken off the market, redesigned, reintroduced, and we go back and forth. So that's kind of in a nutshell the status of total knee replacement.